Warm greetings from New York. I'm Enrico Asher, the Executive Director of the Frank J. Veith International Society and the co-moderator for this webinar. Let me start by thanking all 33 previous vascular fellows trained at Montefiore Hospital for their commitment to creating the society to honor our mentor and friend, Dr. Frank J. Veith. One of the goals of this young society is to encourage surgeons to develop new concepts, techniques, and devices to better understand vascular pathologies and to improve the management of our vascular patients. Accordingly, we created this award called Innovation in Vascular Surgery and Endovascular Therapies. The response has been great. Close to 40 excellent abstracts were submitted, and these were judged by an internationally recognized faculty, and I want to take the opportunity to thank them for their time and effort. Let me please recognize them by name and country of origin. Professor Zhong Chen from China, Dr. Matthew Egerton from the US, Professor Alison Halliday from England, Professor Stéphane Hollande from France, Dr. Carlos Hinojosa from Mexico, Dr. Juan Parodi from Argentina, Dr. Arno von Risto from Brazil, Dr. Cynthia Shortell, and Dr. Frank Veith from the US. Many of them are here with us today, and we are looking forward to their comments and questions. Unfortunately, Dr. Juan Parodi has been caught in an urgent and unforeseen responsibility and will not be participating in the webinar, but hopefully will be watching most of it. Thank you very much, Dr. Parodi, for being our great president in this challenging year. I would be remiss if I don't recognize the support and expertise given by Pauline Mayer, our marketing consultant for the Frank J. Veith International Society. Thank you, Pauline. I also want to extend my thanks to Jackie Simpson and David Stackover for their technical help. Today, it's all about the winners of this competition. And for this, Dr. Parodi and the Executive Council have invited Dr. Veith to moderate this webinar. Thank you very much, Frank, for accepting this last moment invitation. It is a pleasure to have you run the webinar. But before I pass the microphone to you, let me remind the presenters that their talk should not exceed 6 minutes, and each will be followed by a 5-minute discussion period. Dr. Veith, please, for your comments.
Well, thank you, Enrico. We all know that innovation and research directed at innovation is the lifeblood of medical progress and the essence of advances and leadership in vascular surgery. It is my fond hope that this society will promote innovative research in vascular surgery around the world by recognizing creative and innovative research accomplishments such as we're doing today. We also hope that this society's impact continues to grow as more folks become aware of the society's mission of recognizing vascular surgery innovators, and as the society gains support both from vascular surgeons and our industry partners. I certainly applaud Enrico Asher for starting the society, thank him, and I applaud him for promoting its mission of recognizing vascular surgery innovation and its innovators. So Enrico, thank you, and the floor is yours to introduce the winner.
Thank you very much, Frank. Thank you. It's your work and enthusiasm for vascular surgery that has motivated us to continue to contribute to this specialty. It is my great pleasure to announce that after a tough competition, which is not easy, we had to sleepless nights to decide who would win it. And I am not the judge, but all the international judges gave their mark, and the end, who won was Dr. Mark Kashwick, who won. And Dr. Kashwick is from Hamburg, Germany. He works with Professor Devos and many other very well-known people. But today he is the champion. He's the one who won this award, and his work is on the pilot study to combine robot assistant and duplex guidance for peripheral endovascular interventions, the ROGUS PAG project. So Dr. Kashwick is going to let us know how is this pilot doing. Dr. Kashwick, please. Are you sharing your screen?
Mark, you might be muted.
So I'm sorry, I missed the last sentence. Sorry.
I say you
Because-
agreed. Let's go with your talk. You won.
Okay, sorry. Okay, so I start. So thank you very much. It's an honor to present our project today to this audience here. And thank you to the judges, and I start. So why is it working? Great. Let me start again. So hopefully this works. Yes. Okay. During this, I have no conflict of interest regarding this presentation. First of all, what does the acronym ROGOS PAD means? It means robot-guided ultrasound system for peripheral arterial disease. So if we think about the disadvantages of conventional endovascular interventions, it's primarily the use of X-ray and agents. So if the first goal of our project was to look for alternatives, and as the most promising alternative, we turned out that duplex guided ultrasound has already proven to be feasible in a clinical setting. Especially the work of Professor Asser inspired us. So what are the advantages of ultrasound versus X-ray? First of all, we have no X-ray, so we have reduced X-ray exposure. We have no risk of contrast-induced renal failure or contrast agents. We have a fast and safer access to the artery, which depends on the surgeon. But we have a real-time visualization of catheter malposition. And to my mind, the biggest advantage is that we have a real-time visualization of hemodynamic parameters. Possibly we have 3D reconstructions with the help of modern ultrasound heads. So, but the biggest disadvantage, if you think about peripheral interventions, is that it is impractical for the interventionalist to guide the ultrasound probe while he's doing his intervention, because he needs both his hands. So this is where the idea of the robot arm comes in. In the ROGOS PAD project, it is planned that the robot arm will guide the ultrasound probe. So if you use a robot, you have a precise transducer control. You can have a memory of points and accurate return to them. And you have no exhaustion of the examiner, which in turn will lead to a precise transducer control. So because our robot system is not approved to work on a human in a clinical setting, we first developed Phantom, which is perfusable and ultrasound capable. And we use 3D printed patient-specific models in this Phantom. And here you can see how it works. If it is perfused, on the right side, you see the Phantom, and on the left side, the human artery and duplex ultrasound. And as you can see, it's working pretty authentic. So this is the setup. The ultrasound probe is guided by the robot, and the current position of the ultrasound probe is combined with the ultrasound image, and then the new position is transmitted to the robot. Okay, and this is how the scan works. First of all, the robot arm gets contact to the surface. Then in the y-axis, a movement is done if the vessel is detected. And then there is a correction in the x-axis, and the algorithm starts again till the whole vessel is scanned. This is how it works on the Phantom, just to give you an impression. And this is accuracy analysis that we have done of the movement of the robot arm in 2 directions. And as you can see, the robot arm can reliably contact and track the vessel. This is actually working pretty well. Here you can see a special mode. It's called the hand guide mode. Why is that important? Because we work with collaborative robots, and they were initially developed to avoid contacts with humans. So as you can imagine, this is not really helpful if you want to use them for an ultrasound guidance. So we had to change this completely. So what are the next steps in our project? We are looking for a fully automated robot-based visualization of the entire vascular tree in ultrasound with hemodynamic parameters, a so-called ultrasound angiogram. And we are looking for automatic detection and tracking of the guide wire. And at the end, we want to do a clinical pilot study according to the Medical Device Act. Furthermore, we want to implement some already established techniques, as you can see here, real-time fusion of CD, of ultrasound and CT data to give a better visualization during the intervention. And this is where we want to go. This is the future. We are looking for a full optimized assistant system for the surgeon, so that the robot will guide the ultrasound probe during the whole intervention. So this is our project team, and we are very proud that we get a funding of the German Research Foundation for the next 3 years to go on with the project. And I say thank you for your attention, and best wishes from Lübeck and Hamburg.
That was great, Mark. Excellent, really. Very exciting work. It's open for discussion if anybody wants to jump in.
I have a comment, Enrico. I congratulate Mark. I think this is absolutely the perfect winner for our first Innovators Award session. I think this is great work. I have one question. When Enrico first introduced this many years ago, I had trouble understanding why more vascular surgeons and interventional cardiologists and radiologists didn't jump at the opportunity to avoid ionizing radiation. And it was a lot of people, including ourselves, tried to adopt this technique, but it was clear that Enrico had a huge asset in Natalie Marks, who was a really spectacular duplex technician at the time. Now she's a full MD in the United States. But can the robot reproduce the excellence that is required of the technical expert and get the same results? Do you think, Mark, that's going to be a no-brainer, or will that be an obstacle?
Yeah, it's a very good question, but I think when Mr. Ascher started with his research work in 2004 roundabout, we didn't have techniques like artificial intelligence and so on. So I think with the new technologies, especially with this fast progress in these technologies, I think in a couple of years, it's absolutely doable that the robot can assist a surgeon during this procedure. I think this is absolutely doable. And to date, we have much better ultrasound probes that we had 20 years ago. So we had the opportunity of using 3D ultrasound probes. And I think with the technical approach in these clinical parts, it's absolutely doable.
Yeah. Yes, Carlos, you're muted. You're muted.
Yeah. Thank you. I would like to congratulate Mark and his team. And I would like to ask if it is feasible to have this technology with, or we could have this technology in the future with a headset virtually lenses.
Yes.
Glasses.
Yeah, we're already working on that. We use the HoloLens from Microsoft in a different project. It's called NavEva, where we try to overlay a CT scan on the body. Just it's a kind of, as I have shown in the last video. So at the very end, we are looking to have a kind of radiation view. I mean, we want to avoid radiation, but we want to look inside the patient while we are doing the intervention. This should be the end of the whole project. So yeah, we are thinking about this, and we are already using this.
I mean, if you start with the AV fistulas, for example, in the upper extremity, it's much easier than trying to go to the adductor canal or the proximal popliteal artery above the knee, because that's, you have to change the probe direction significantly. But for the proximal and mid SFA, is cannot be anything easier than using your equipment with the robotic, because only has to go one way, or even slight rotations. So I think it's very doable. I did some work with Philips with robotic arms as well, but we are far from getting into the hands of the vascular surgeon or interventionist. But I think what you're doing is great and should continue, because again, there's no radiation. And like you said in your talk, you also get hemodynamic information immediately that is not available on when you do standard procedures with the contrast material and radiation exposure. So congratulations once again. We have to move on. Hopefully you'll stay for the other presentations, and thank you again. Frank, would you like to introduce the next one?
Yeah, sure. Our first honorable mention goes to Hernan Bazan from New Orleans, the Oxner Clinic, and he's going to present his work on the delivery of potent neuroprotection after ischemic stroke. Welcome, Hernan, and congratulations.
Thank you very much, Dr. Veith and Dr. Asher, and to the program committee for this privilege. Like all of us, we all look forward to being together in New York, hopefully soon. I'm going to just share my screen now. So good afternoon, everyone, and good evening in Europe and in Asia. I will talk about the delivery of potent neuroprotection after ischemic stroke. Currently, there are 15 million strokes annually worldwide. And the question is, how can it be improved further in terms of their recovery? In 420 BC, Hippocrates described stroke as apoplexy, someone being struck down by violence. And really, over 2,000 years, there was very little treatment for stroke. In 96, this was disrupted with the advent of TPA, where it was shown that if it was given within 3 hours, some patients, in select group of patients, there could be a reverse in their neurological deficits. In the mid-2000s, stroke centers and telemedicine, in a coordination of the specialists and the centers that could treat these patients, occurred, and with increasing outcomes favorable to the stroke patients. In 2015, multiple trials demonstrated that intracranial thrombectomy had also a positive effect after several years of failed trials, showing clearly a benefit in small and mild to moderate strokes in terms of neurological outcomes. And this is extended 3 years later for wake-up strokes, for strokes up to 24 hours, where intracranial thrombectomy demonstrated improvement. However, in all of these trials, at best 40 to 50% of patients qualified. And of those that qualified, at best 50% had some neurological recovery. And a real reason for this is because the penumbra imaging demonstrates that multiple patients that come have a poor penumbra, a poor viable tissue that's ischemic but salvageable. And these patients are often denied therapy that I will describe in a couple of slides. And so henceforth, a question for the future is, can a potent neuroprotection delivery be done to the penumbra after an acute ischemic stroke to preserve it? And that is really what I think will be the future of stroke therapy. The penumbra, again, is tissue at risk that's at the site of a core infarct, and it really is based on the collateral circulation. And so a question, can the penumbra be preserved further after a mechanical thrombectomy, perhaps can be answered by potent neuroprotection delivery to the penumbra after an ischemic stroke. Our group has discovered in 2017 and beyond potent autogenous, endogenous pro-homeostatic agents that we've termed elovenoids. And these are upregulated endogenously after an ischemic stroke. And this may be why we observe some patients that have some recovery and some that don't because of these endogenous agents. This is an experimental model a small animal model after a middle cerebral artery occlusion. And one can see in the bottom two panels, a much larger preservation of viable tissue, decrease in the core infarct. And in these last two columns, the 3D volume lesions markedly decrease when the elovenoids are delivered either intravenously or intrathecally. Currently, clinically, we have a unique situation that we didn't have before. Following mechanical thrombectomy, an aspiration thrombectomy is done or stent retriever is done to remove the thrombus in the anterocerebral or middle cerebral branch. And this is different from what studies that were done several years ago where things were delivered systemically. And because they can be delivered at the site of the lesion, bioavailability issues probably going to be resolved, as well as systemic side effects. When a patient comes in currently with a stroke, they are imaged, the penumbra is imaged with some sort of modality. One of them is a multi-phase CTA like this one, where in the top panel, one sees a large amount of good collaterals demonstrating a good penumbra, large penumbra, and these are often offered therapy. However, patients with intermediate collaterals or a poor penumbra are either denied therapy or they may or may not receive therapy, really depending on the interventionalist's enthusiasm and aggressiveness. And so it is plausible that if a potent neuroprotection is developed and it can be delivered to the penumbra, patients that are currently denied may be able to undergo thrombectomy with the hope of further preservation of the viable tissue that's at risk, or the penumbra. And even patients that are offered therapy, often they don't have full neurological recovery. The ranking scale doesn't go down to 0, maybe not even 1. They may leave the hospital with a ranking scale of 2, meaning some neurological dependence. So it's possible that such agents could help patients gain much further functional independence. Currently, there are 3 active trials in phases 1 to 3 for neuroprotection agents. One is something that's well known to all of us clinically, verapamil to treat vasospasms, and 2 others that are work at the neuronal cell level at the NMDA receptor. However, all of these are single acting agents, and what's needed is really something that acts with multiple modalities. These molecules, the elovenoids, not only work at the NMDA receptor, but they're also anti-inflammatory, and they help a lot with the edema and the reperfusion that we see clinically after these reperfusion procedures. So currently, to sum it up, a best 40 to 50% of patients are helped with lysis and mechanical thrombectomy. And this has been borne out by increasing data from now the past 5-6 years with mechanical thrombectomy. And I think we've reached a plateau in terms of the amount that can be gained with just mechanical treatment. The future is likely going to be elucidation of a potent and selective neuroprotection so that patients can have a larger functional recovery, larger independence, lower ranking scales by preserving the penumbra and progression of the core infarct. And henceforth, hopefully 50 to 60% of patients that are currently not helped and denied will be able to be offered this therapy. I'll stop there, and thanks again to the committee, and I look forward to discussion and really look forward to November, Frank. Thank you.
That was excellent. I'm sure there's going to be some discussion from our panelists.
I have, this is Matt Eagleton. I have two questions, if you don't mind me asking them.
Please.
Mechanism of action, is this, are we rescuing ischemia-induced apoptosis? Do we know what the downstream effect is and what we're targeting specifically? That's the first question. The second question, I'm not a guy that does a lot of carotid work, but I do a lot of thoracoabdominals, and we have spinal ischemia, and I'm wondering, has this been thought of as a way of rescuing spinal cord ischemia being given intrathecally?
Yeah, thank you for that question, Matt. Those are real poignant questions. Absolutely. So luckily the mechanism of action is quite well delineated. I touched upon it a little bit. It does work in the sort of final common pathway in terms of neuronal cell survival. It's not apoptosis, but it's through the NMDA receptor. They're also quite anti-inflammatory, so it also would help with the reperfusion injury and the edema. And they're quite hydrophobic. So if they're delivered at the site of the core infarct where the thrombectomy is done, they have a much larger chance of eluding to the nearby penumbra. So those are in a broad sense, three different mechanisms. As you know, if it works in one neural organ, it should work in another neuronal organ. And so absolutely, it could also help potentially quite a bit, like some of the other NMDA receptor antagonists are being evaluated for spinal cord ischemia during thoracic repairs.
Yeah. Hernan, you mentioned that multimodal approach may be the way to go in these cases. I wonder if you ever, of someone or you ever tried adding L-arginine to the solution, because that has been also shown to be cellular protective in several areas in the body, like renal ischemia and skeletal muscle and other places. Has any of these work done?
Sure. We ourselves have not used L-arginine in the experimental stroke models, but you're absolutely right. That's been described, and it has some protective, has been elicited to have some protective effects. There may be some synergism, and that certainly could be something to look at in the future, for sure.
Very interesting work. Dr. Arno Varisto, please. You're muted, Arno. Arno, you're muted, please.
Sorry. Congratulations on most interesting work. I would like to ask you, Hernan, if does the size of the ischemic area impact in the effectiveness of the neuroprotective drug studied?
Well, that's an important clinical question. The only data that we have are on experimental stroke models. And so that's elucidated by occluding the middle cerebral artery. We would suppose that obviously the larger the core infarct and the lower the penumbra, the less clinical effect that one would see. But given the experimental data that we have, we feel that the larger the penumbra, the larger the chance of recovery because of the way it works. So it would be effective in patients that have even large strokes, but if they have large penumbras, that they could potentially really benefit from something like this based on the experimental models. But if for some reason they have poor collaterals and very poor penumbra, they're unlikely to benefit as much.
Yeah, Hernan, Anil Hingarani asked the question, are there detrimental side effects to these potent agents?
Well, thank you for that question. So this is, as I mentioned briefly, endogenously produced to low levels. And we've all had patients clinically that have come in. We do a lot of acute strokes through our telestroke program in our area. And it's amazing. We see patients that have good recovery after TPA, some don't. It may be because of penumbra, and maybe because of some endogenous agent that's expressed. So this is actually something that's synthesized endogenously, and that's how it was discovered. And so obviously it's synthesized. So it is not, we have not seen toxicity. One of the things that's next to be done is obviously as GMP grade of this is synthesized, then to test it in what are called GLP, good laboratory practice toxicity models in larger animals to make sure there are no, at high levels, no dose effects in the liver or in the kidney, but it is something that it is endogenously produced.
Great work. And Enrico, I think we do have to move on, right?
Yes. No, we don't have to. I mean, we can ask some questions if you have any other thoughts or any comments. It's okay. We're waiting for Dr. Guo, who is unable to connect to our webinar. He's trying very hard from China. It was an amazingly good talk and technique. So we're gonna probably leave him for the end and just move on with the presentation. So Frank, if you can.
Yeah, no, I must say there are a lot of questions to Mark that I see on the question Q&A, and hopefully Mark, you can check these questions out, and they're all from first-rate people that have experience with duplex.
Absolutely,
imaging.
I'm already working on.
So even though we didn't get to ask
answering.
them, you can answer them.
Yeah.
So we'll move on to Jacob Schneiderman, who hails from Israel, the real winner of the vaccine distribution contest in the world. And Dr. Schneiderman is going to talk on local anti-leptin therapy may prevent cardiovascular complications in Marfan syndrome. Dr. Schneiderman, the floor is yours.
Good afternoon. I'd like to thank the Frank Veith International Society for choosing my research to be presented to you today. These are my disclosures. Marfan syndrome is characterized by aortic root aneurysm, dissection, and by rupture if untreated. Through our previous studies, we studied the mechanisms of generation of aortic aneurysms. And we found, and others, that TGF-beta and Ang2 are elevated in Marfan patients, and they are both promoting aortic root aneurysms. Our research actually directed us to discover the role of leptin, which is induced by Ang2 and is a very powerful mediator of Ang2, capable of promoting medial degeneration and causing expansion and aneurysm formation. So after we found in another study that levels of leptin were very high, newly synthesized in patients with Marfan syndrome, we hypothesized that maybe leptin is the driver that actually causes those aneurysms in Marfan patients. And by counteracting this leptin activity, we could actually inhibit the formation of the aneurysms. To do so, we elected to use a leptin antagonist, in short LEPA, that was incorporated within a PLGA film that was applied to the proximal ascending aorta for a slow release during 30 days using a Marfan mouse model. As anticipated, we found that the aortic root of Marfan mice actually progresses in terms of diameter, growing very, very rapidly. However, Marfan mice that received the leptin antagonist on that patch, on that film, actually didn't expand the aortic root. It stayed the same as at the initiation. In histology, we confirmed the presence of medial degeneration with multiple fragmentation of elastic fibers, depletion of smooth muscle cells, thickening of the vessel wall. But in contrast, we saw that those that were treated by LEPA actually preserved their integrity and they looked exactly like the wild type glutamates that were used as controls. Now, we also performed analyses for macrophages and for MMP9 in those tissues from both groups. And only in Marfan mice that were unprotected by LAP-A, we found infiltrates of macrophages within the media with abundance of MMP9, which, as I said, were absent in those that were treated by LAP-A. Further analyses of the wall of the aortic root actually showed upregulated leptin, TGF-beta 1, phosphorylated SMAD2, and ACE1 that were very prominent in Marfan mice. But those that were treated with LAP-A actually did have practically none of those. Now, looking at the heart, in Marfan syndrome, the left ventricle is actually exposed to a very, very excessive workload due to outlet obstruction, which is caused by the hemodynamic perturbations in the aortic root. Now, through aortoventricular coupling mechanism, the left ventricle experiences elevated pressure and some degree of strain on the inner walls. So those Marfan mice developed actually induction of ACE1 and leptin in cardiomyocytes of the left ventricle. This was not seen in those that were treated by LAP-A. I don't have those slides here. But the outcome of this event was that Marfan mice developed hypertrophy of the left ventricle, as you see here, and remodeling of the valve leaflets, both in the aortic valve and the mitral valve. While those that were treated and protected by LAP-A didn't have any hypertrophy and no sign for remodeling of the leaflets of both aortic and mitral valves. We assessed systolic function in those mice through different parameters. Here I bring two, and systolic diameter and ejection fraction. And as you can see, in red is the one that was receiving leptin antagonist. The function of the left ventricle in terms of systolic function was preserved within normal limits, within normal range at 4 weeks. And the same applies to ejection fraction here. In contrast, those that were actually not protected, the Marfan mice in blue, showed significant impairment of the systolic function of the left ventricle. We measured blood pressure in Marfan mice and found that they had systolic hypertension. Those that were treated with LAP-A after 4 weeks actually resumed to the normal range and had no systolic blood pressure, while those that were not protected actually had the same hypertension. Therefore, I gave you some highlights from our study, and I hope I managed to bring it home to you that leptin hormone is an inducer of aortic aneurysms. And our way to treat it is unique in terms of using a local approach, applying a mini dose of leptin antagonist to block the leptin activity in the vessel wall. And by this approach, we can prevent medial degeneration, expansion, and subsequently aortic aneurysm formation. Now, if we preserve the integrity of the aortic wall, we also maintain the normal structure and function of the left ventricle. These data, in our mind, suggest testing the same model, the same approach for clinical implementation to be used in patients with Marfan syndrome, so they can actually confront and attenuate symptoms, cardiovascular symptoms that are typical for Marfan syndrome. Thank you very much for your attention.
Well, Professor Schneiderman, that is absolutely fascinating and innovative work, and I applaud you for bringing it to our attention. I have a couple of questions. The first one, I'm not expert in this area at all. What is leptin? Where does it come from? And the second question is there any other way of administering LEP-A other than wrapping the aorta with a something, because so that it distributes the LEP-A over time? Because ideally, you'd have to give it to all Marfan's patients prophylactically, because once they develop an aneurysm, it's too late to put the patch on the outside of the aorta. So can you give it parenterally in any way, and what is it?
Well, it has to be local, and it can be administered anytime. The beauty of this model is that you can initiate anytime, and you practically freeze the size from that minute on. When we started with those mice, they were already dilated, those aortic roots, because they start to dilate in utero. So when we started the experiment, we had to wait till they were 7 weeks old in order to perform surgery, thoracotomy on those mice. So the aorta was already dilated to some extent, but from then on, there was no expansion beyond that size. That's the issue. Of course, it's ideal if you think in terms of clinical application to start early before the aorta has expanded to some significant size. Now, it has to be local, because LEP-A cannot be administered systemically. It may cause perturbations in terms of hormonal perturbations. The issue is we are talking about mini dose, so small, such a small amount of material. We couldn't find any trace systemically, and it was very effective locally with no systemic effects whatsoever. So the question that you raise regarding administering this substance is very critical. And the point is, since we need to keep providing the substance to that individual, to that subject, in the future, if we implement this clinically, we'll have to find a way to replenish that source which goes and is surrounding the aorta from the outside and from the inside, in order to provide that material to that wall in order to block leptin activity locally. The rest of the body is not affected at all, just locally.
That's fascinating. Again, what is leptin? I never heard of it.
It's a 16 kD hormone, which has a lot of functions. It has functions in food and energy consumption, and it is responsible. It has functions in endocrinology, in hematopoiesis, and many other, and in inflammation. It is a very, very potent and very, very significant hormone in the body, which is practically an essential hormone.
Okay.
So
any other questions?
This LEP-A is a mutant of leptin. So they took leptin and they replaced 4 bases only in that basic leptin molecule.
Right.
And this is the antagonist.
We have a question from Dr. Peter Klovitsky, who is asking, Is there any evidence that LAP-A indeed penetrated into the wall of the aorta, where the controls operated and treated with the same technique without LAP-A?
Of course, yeah. There was the lab, the other control group actually underwent the same surgery. They had the same film of PLGA that was devoid of leptin antagonist. So they had the same kind of trauma, and the same PLGA was applied to that aortic wall, but they behaved like other Marfan mice that progress the size of the aorta and actually complicate their left ventricle.
Very interesting. Thank you. That was really great thought work. Yes, Dr. Arno. You're muted again. You're muted.
An intriguing question. Can this data be applied to all degenerative aneurysms? Do you believe that there's going to be a place for that?
Well, I think based on our studies, it should apply to all aneurysms where Ang2 is involved. Since it's a mediator of Ang2, leptin is being synthesized locally in those aneurysms. And if you use LAP-A, you will block the activity of leptin. Thereby, you will cut the option for the leptin to promote medial degeneration and push it towards the formation of an aneurysm locally. So my view is that it will be practical, available to be used not only for the aorta, but for peripheral arteries as well. Any place where Ang2 is involved in the process of remodeling.
Fascinating.
Dr. Hinojosa has a question.
Thank you. I would like to congratulate Dr. Jacob, Professor Jacob. It's interesting work. Do you think this could be related to some receptors in the endothelium or in the medium to respond to this inhibitor?
Well, the mechanism by which it works is it competes with the leptin over the leptin receptor. Now, this leptin antagonist is unique because it has a 60-fold higher affinity to the receptor than the native leptin. So it will actually be caught by it will complex with the receptor, the leptin receptor, and consume the locally available receptors in that area. So the native leptin, whatever amount is there, that we cannot, I mean, it doesn't care because it has no receptors to attach to. So that's the beauty of that option, that mechanism. So you actually, you occupy all receptors with this specific antagonist, and the complex that the antagonist forms with the receptors is inactive. So that's how you neutralize actually the activity of the leptin locally.
When are you going to try it on patients? Soon, I hope.
It's a long way to go, you know, from your experience. We have to, we are now actually trying to work out a system that will allow us to deliver in humans, and also a system that will allow us to replenish that leptin antagonist chronically, because otherwise it doesn't worth it. It's not an acute therapy. You start it and then you go on for life. It has to go on for life, but it can be a standalone therapy, and you know, it's local. Not to mention the problems with systemic therapies for Marfan syndrome. So many adverse responses and so many problems. If you start treating a patient with this at an early age, and you find a solution how to replenish that substance and actually stop the expansion and stop the cardiac complications which are related to the aorta, then you are a winner.
Right.
You need to have a bladder with the LEP-A in it and a method for
Sort of,
squeezing
yes.
it onto the aorta periodically.
Some sort of a reservoir. Yes,
Yes.
yes, absolutely. You are right.
Yeah. Matthew and then Stefan, please.
So I'll deviate from the aorta a little bit. Is leptin involved in the other anatomic malformations seen with Marfan's? And if it is, could this be used such as like ocular eye drops of LEP-A to prevent some of the ocular manifestations? Seems like that'd be an easy application of it.
Well, this is something we haven't tried. We know that leptin is involved in many pathologies which are characterized by remodeling. Wherever Ang2 is involved, leptin is there. So if leptin is there, it's bad news. If you can actually attack the leptin locally and stop that deleterious process, that's a big advantage. That's the issue. Now, by the way, I didn't present it, but we managed to show in those mice that the main pulmonary artery, which is adjacent to the aortic root, was already influenced by the LEP-A by proximity. So the LEP-A that was in the film permeated into the main pulmonary artery, and characteristically, the main pulmonary artery should undergo expansion like the aorta, but in those cases treated by LEP-A, the diameter was unchanged by 4 weeks.
Professor Holon, please.
Thank you, Enrico. Hi, everyone. Congratulations to all the speakers. I would like to echo Frank Veith, Professor Schneiderman. How do you view the future? The way I look at it is that most young patients that would undergo acute type A open repair, they usually have an ascending graft position. Do you think that leptin position at the level of the root would be a way to prevent future bentall procedures?
You should expect to see effective therapy or effective contribution of the leptin antagonist wherever you put it locally. It's very limited to the location where you apply it. And this is the advantage and maybe some disadvantage. But you have full control over the place where you actually apply and treat that segment. So if you have a segment which is prone to develop dilatation and you detect it before, you can do some proactive treatment and apply that patch, ring, whatever it is, which actually gets release this leptin antagonist locally, and you can actually stop any process of expansion in that area.
So I think that's really the future, because by treating the patient with a simple tube and wrapping your leptin patch over the root, you will probably prevent a lot of those bentall procedures that are required in the future. So I see a bright future for your technology. That's fantastic for our patients.
Thank you very much.
Thanks, it's really fascinating. Professor Shane, I am so sorry, but despite several attempts, we're unable to get Dr. Gould to do his presentation, which is fascinating. And I'll say that half of our judges are here exactly to listen to his presentation and make comments. I know Professor Holon was ready to start. Would you like to make some of the comments now, please? Professor Shen?
Professor Gould, maybe have a line. Maybe you can try.
Now, would you like to make some comments about this meeting at all?
Maybe can try again, I think.
Okay, so we're going to continue to let him try. He's been trying. We have our RT people also trying to get it. But in any event, what we're going to do is we're going to get his recorded presentation, and it's going to be at the Frank J. Veith Society site for the next couple of years. So all of us can can really not only listen, but make comments on it, and he will respond. So nothing lost. We're going to move on then with our last but not least speaker, Dr. Tej Singh, who's going to talk to us about intermittent pneumatic compression device helping global access care and costs, created by a USA vascular surgeon. Dr. Singh, please.
Great. Well, hope everybody can see my slides, and I thank everybody for this opportunity. I want to recognize Dr. Veith, Dr. Asher, Dr. Perotti for this great opportunity. I'm going to share with the audience today, and I thank you all for waiting through this wonderful session, the device that I've been working on for many years, and it kind of is a journey story. And I think that there's many people from across the world who are listening to this presentation today, many of them who I'm really thankful for their guidance. So we can get started here. Disclosures, I am the CEO and founder of this company. I am an active vascular surgeon. I also have all the intellectual property on this device as I've been working on it. And while still a busy vascular surgeon, I've been living the life of an entrepreneur. And as this device is now commercially being rolled out across the world, not presently available in America, so I want to make that as a clear disclosure today. Really, the story of me and this device started about 30 years ago when I had the great opportunity of working with probably the #1 cardiovascular pathologist at the University of Chicago, Dr. Seymour Glagoff, and his work on coronary atherosclerosis and his work in partnership with the vascular surgeon, Dr. Christopher Zarins, there was really my start in my career as a vascular researcher, vascular scientist, and eventual vascular surgeon. So I really thank those days back in Chicago in the late 80s when I got my first experience with these arteriovenous fistulas. I carried that forward with an amazing experience at Stanford University with Dr. Zarins and his laboratory, and my passion, continuation for AV fistulas, flow, how a vein outflow adapt, how those veins adapt. Living here in Silicon Valley and training at Stanford University got my juices going for eventually making this kind of a device. And of course, my time in Japan with Dr. Masuda, the #1 arteriovenous fistula pathologist in the world, really gave me the journey and the foundation to understand arterial wall, venous wall adaptation to various stresses. And with that foundation, I started my career as a vascular surgeon. When I learned in the community that vascular surgeons really struggle with arterial venous fistulas, maturation, but the real concept of chronic kidney disease is a global problem. While many Americans struggle with chronic kidney disease, the global population in Asia, Europe, Latin America continues to increase. And this will be a disease that will continue to need innovation. And there has not been innovation in this space. And many of you at the Veith conferences in New York have learned about the needs for innovation in vascular access care. It was clear to me that AV fistulas, while they are surgery, and that is a connection between the artery and the vein, that outflow vein, the outflow vein of that AV fistula is so crucial for the success of these patients, for their care. And if we look at fistulas, the amount of fistulas that we can do on someone's arm are increasing with the recent discovery and approvals of endovascular AV fistulas, but the snuff box fistula, the upper arm fistulas, they continue to be successfully done, and of course AV grafts can be done. We thought about making a device that really could be a device for all the fistulas. We know fistulas have a failure rate. They fail, they don't mature, the time, the cost are very, very dismal. We thought about making a device that could be helping the outflow vein, that could help these fistulas, decrease costs, give patients a better outcome, help with many aspects of the care of these patients. The science was very clear. A fistula and a vein and the outflow vein of that connection must adapt to it to be successful. It must adapt to wall shear stress. It must adapt to wall tensile stress if we can make that another factor in these AV fistula outflow veins. And thus the creation of a device based on clinical science. Patients all across the world were told to use rubber bands to compress their outflow veins. People have been told to use exercise balls. We tell our patients all the time to do this. What we're doing here is altering wall shear stress, altering wall tensile stress, and of course, releasing with those changes nitric oxide. The science has proven that. But once again, I really want to emphasize, it's the outflow vein that is the success of these fistulas. Technically, it's important to have a great artery and a great fistula and a great connection. That outflow vein has to adapt for those needles to work. The Fist Assist device is a very simple external pneumatic compression device, first presented globally at the Veith Innovation Award session in 2015, where Dr. Veith and Dr. Oriel had the first innovation session. And at that time, the efficacy of this device was being tested in Bangalore, India. It's an external wearable pneumatic compression device that alters the wall shear stress, wall tensile stress in a safe external environment on the outflow vein. The outflow vein at a pressure of 60 millimeters of mercury, intermittent pressure for 20 seconds, and cyclic was the concept that we developed based on all those years of our research and our understanding. We wanted Fist Assist to be the global device for the global renal failure patient before surgery, after surgery, helping the outflow vein mature, and of course help with cannulation, and of course many other indications which are being intellectually protected because of the use of this device in primary studies. Our competition is the rubber band and the squeezy ball, but we think we have a device that's got much more use and much more compliance. We did stage 5 feasibility studies, the device on fistulas, no thrombosis, no infections. Efficacy study in 2017 done in Bangalore, India. Once again, the fistulas continue to enlarge, the proximal portion of the fistula enlarge, no complications, no thrombosis. With that led to the start of a trial which is still in process of the FACT trial for a global pre-vein dilation indication. And of course, with Fist Assist and our company, the interest in maturation, cannulation, heal, eventual mental health with hope is all a part of the renal care journey that we want to attack and help with this device. The papers have been published in the Journal of Vascular Access, Journal of Kidney Care. You can find these. I won't allude to them today. But in summary, what we want is to use the science that has been studied for many years globally and use it to make it for a device for all aspects of renal care. Our company is committed to the renal care journey and all aspects of that to educate, engage, enable, and empower the outflow vein. Presently, the device, and I'm very happy about our global registry, continues to expand. The device is safely being sold in India, Europe as a CE mark class 1, Australia and Canada, and all these, and the partnership with Amazon has made patients have this device. The question that comes up a lot is about the America market. At the present time, we're very excited about our ongoing discussions over the last 5 years with the FDA. The device has obviously got a novel, unique, one-of-a-kind flavor to it. Presently, according to the FDA, it's a non-significant risk if we use the device pre-surgery. This means before someone has their actual fistula surgery, the patients can, according to the FDA, it's a non-significant risk, and we will continue to learn about that trial and see how that trial can play out. According to the FDA at the present time, after AV fistula surgery in America, after making the connection, there is a significant risk of the device causing wound complications, wound separation, AV fistula surgical thrombosis. And these discussions are continuing with the FDA. The ongoing exchange is really important for us. And I think that while we have not seen any of these complications globally, we will continue to work with our FDA partnership and try to understand how we can bring this device safely to the America market. It is a top priority for us. Ultimately, the trials are going to continue. We think we have a concept here called intermittent focal vein compression, IFVC, basically a device that started out in the minds of many people at the University of Chicago and at Stanford, and the concept of bringing this to fistula care for dilation, maturation, cannulation, and eventual steal phenomena with ongoing trials is very exciting to us. We think we have a device that's the full spectrum of renal care and can help at all levels of this. Just from the final 2 slides here, just the cost benefit. This basically shows when an AV fistula is created in America. If the AV fistula develops well, the annual cost for that fistula is $7,000 for the year. If that fistula doesn't develop, that fistula needs $25,000 a year. and of course 60% of fistulas in America are not successful. If FistAssist sets the bar low at a 20% improvement, we will save the America market $512 million in fistula improvement, whether that's in fistula dilation, fistula maturation, help with cannulation. This space and this science is so needed, not only in America, globally. And of course, with the endo-AV fistula world, we need larger veins. Maybe there's a role with endo-AV fistulas for FistAssist. FistAssist has positioned itself as a global device for all aspects of renal care. The RDMC protocol is all about dilation, maturation, and cannulation, and eventually giving these patients hope. I thank the judges, I thank the Veith Society, I thank Dr. Perotti, Dr. Asher, and really I want to thank all my mentors, in particular Dr. Christopher Zarens. His guidance, his success, his input in my career has led to this company, has led to FistAssist, and my passion for AV fistula care globally. Thank you all.
Thank you very much. Very, very interesting work, and seems like making a major impact globally. Open for discussion. I think we have a few questions here also, but open for
Can I ask a quick question? Why is it taking the FDA so long to approve it for pre-fistula creation use? There doesn't seem to be any negative or downside, and perhaps you can do a quick controlled study, randomized controlled study, and show that it definitely makes for more successful fistulas.
Yeah, Dr. Veith, thank you for that discussion. As you know, we've been working with the FDA for about 5 years on this project, and we have a wonderful collaborative discussion with them. We're trying to figure out the space for this device, whether it's a dilation device pre-surgery, whether it's a maturation device. And those discussions and those trials need a lot of input and a lot of direction from the FDA. But your point is very well taken. We as a company are fully committed to all resources, time, and energy to get this device, just like the rest of the world has it, onto the American market. Patients need it, providers need it, the healthcare systems need it. And I would hope that with ongoing dialogue and with those trials being completed, we should be cleared for the American market as soon as possible. I can't set a date for that. Globally, it's accepted. Globally, it's safe. It's going to be in America when the time for it to come to America happens, and we're committed to that. But your support and everybody on this video session today, understanding the need for this device, it's really important, and it gives me great hope that that'll happen.
We have a couple of questions from our viewers, from Dr. Paul Yang. He's asking if it is applicable to the upper arm cephalic and/or basilic vein, and what about the use after healing of the incision?
So once again, I think that that's a great question, and I think that right now, if you look at FistAssist, what I can say it's happened in the last 3 years. Right now, the country that has accepted it the most has been India. It is actively selling in India. It's doing very well in India. Patients wear it below the shoulder, so definitely you will get superficial compartment compression of your cephalic vein. Now, if you mobilize a basilic vein, and those incisions, as you know, are medial on your arm, the basilic vein would then end up in your superficial compartment. So this device, whether it's worn below the elbow, as some patients do, or above or below the shoulder, will definitely help your cephalic vein. It can definitely help the outflow vein of endo-AV fistula. And remember, the terminology of that outflow vein is that the highest pressure in an outflow vein of any AV fistula, according to the research done by Dr. Carpeau in France, was 40 millimeters of mercury. We're going up to a pressure of 60, compressing the vein, giving you intermittent wall shear stress changes, giving you wall tensile stress changes, helping release nitric oxide from those endothelial cells. This device can help all types of fistulas in a safe manner on the outflow vein.
Dr. Singh, Victor Navarro is asking if there's any studies in which you show the increase in diameter of the vein, and it is useful when you have a very small vein, less than 2 millimeters.
Oh, that's a great question, and I appreciate that question. So let's break it down into two things. The FACT trial at the University of Chicago and at other sites is gathering data to understand, can it take a vein that's 1.8 millimeters and give it some significant improvement, something for some efficacy. Whether that number is 2.3, 2.4, 2.5, we can argue globally about that. But I do feel, if you look at the basic science, any device, any type of exercise, any type of rubber band on your arm vein will get your vein bigger. So the fist assist device will help pre-surgery dilation, no doubt about it. The two trials that were published in the Journal of Vascular Access in 2018 were basically the device placed on a fistula. And it was very safe on over 56 patients, and it did very well in vein dilation. The endpoint of that study was vein dilation as part of the rule of sixes. The future trial of maturation with our guidance with the FDA may be all about over 1 month patients getting successful dialysis adequacy. Those trials are being discussed, but that's a great question. And I think that that's the future of how this device will eventually get to the American market with ongoing discussions with the FDA.
Thank you very much. I think we got the impossible. I think Dr. Guo got someone to present his paper. And I know we are short in time, but we're going to have to listen to it. It's very interesting. And I want to thank the judge that came to make comments on it. So can you hear me, Dr. Guo or Dr. Wrong, the substitute? Do we have sound, David?
I don't believe he has audio or video.
So should just read the slides out loud? No, they have a video. We can see the video. We have the slides.
Yeah, we just can't. I don't think we can hear his audio though.
Oh, it's a pity. Can he move? Can he go on the slides at least to? Such a pity because a very interesting technique.
In other words, just show the slides. Let everybody read them.
Right.
Can you hear me?
Yeah, we can hear you now. Who is this?
I'm sorry. Very sorry. Dr. Asher?
You did Dr. Wrong, probably.
I'm sorry. You know, many times I failed to log in my personal computer. I have to use a larger desk computer to share my presentation, but this computer no camera, so I can share my presentation. Okay, you can see my presentation.
Yes, we can. You can go ahead. Thank you.
Okay. Dear professors and experts, it is a great honor for me to be nominated for the 2020 International Vascular Innovation Award. Here is the Dr. Guo from the Chinese PI General Hospitals. Here I will introduce about the Veith device, a new double-imaged branch stent graft for aortic arch pathology. I have no disclosure. As we know, there are several devices for endovascular repairs of arch, but still in the validation stage before clinical application. The clinical evidence is still lacking, and the result also indicated the high rate of the secondary intervention, cerebral ischemias, and endoleak complications. These events may be directly related to the device designs and the procedure. We are committed to develop the highly safe and effective stent graft for reconstructing the arch endovascularly. The modular design concept ensures blood supply to the brain during procedure. It is very important, especially in the patient with the lateral trollomen of the arch dissection. The first section is the straight stent graft with double inner branches, 20 millimeter in length and 12 or 10 millimeter in diameter. Since the gutter of the inner branch has been closed already, so the potential endoleak could be avoided. The first section is prolonged in a curved delivery system. Second section are bridging nitrogen stent covered by PTFE, but different structure guaranteed the proximal part excellent radial force, middle part more flexible, and the distal part has the perfect adherent performance. The third piece is a flexible thoracic stent graft without proximal bare stent. It is also preloaded in the pre-curved delivery system, and the proximal part of the delivery system is adjustable. Three pieces collection realized arch reconstruction endovascularly. The first patient of the FAME studies was a 74-year-old man diagnosed as arch saccular aneurysm with the extensive calcification. 3D printed arch model and in vitro simulation showed good patencies of the main body of the branched stent graft after virtual implantation. Bypass between the LCCA to LSA was planted. This picture shows the stent graft deployed before the deployment, and we can see the proximal and the distal markers, and the second picture shows the stent graft after deployment. We can see the 4 ring markers, and then access from the right axillary or right common carotid artery or left common artery to recanonize the trial, and use the 2 balloon expansion to confirm to wear in the 2 embedded stent graft. These are slides shows the bridge stents implantation of the innominal artery and the left common carotid artery and the fellow angiographies of the operation. The CTA follow-up showed the patency main bodies and branches, no endo leak. The second case was the artery shooting element caused by 40 injury 20 years ago. CTA image showed symmetric bilateral vertebral arteries and the small left common carotid arteries. We reconstructed nominal arteries and the left spinal artery because of the left common carotid artery very small. The post-operative CTA indicated as good result as the first case. The number 3 also circular arch aneurysm with obvious cough and hernias. His left vertebral artery was occluded already. The post-operative CTA indicates the patent main body and the branch, no any endo leak. The number 4 was the 4 years old man with obvious chest pain. Examination revealed arch aneurysm for 4 weeks. Post-operative CTA showed the double inner branch stents were satisfactory in morphology and patency. Number 5, post-traumatic artery dissection aneurysm for 1 year. 6 months follow-up CT showed that he had a perfect stent graft morphology and a patent, low endo leak and other complications. For all of the patients, we try to monitor the pressures of the ascending carotid artery and the descending aorta before and after operation, and no clinically circulation pressure gradient was found. Here is the summaries of the case information. 4 cases have completed the 1 week, 6 months, 12 months follow-up CT. Only 1 case completed the 1 week, 6 months follow-up CT, and no endo leak, no other complication. Every branch and the main body stent graft were patent. So very limited result from the first in-man studies. We find an advantage of this device suitable for arch license. Segmental release do not affect the cerebral blood flow. Step-by-step, simple localization and release, perfect stability, and adjustable delivery system, easy bridging technique, no gut endo leak, perfect inner branch morphology, but limitation. Some patients maybe need a bypass between carotid artery and the subclavian artery. A lot of separate study, we are beginning to just 1 inner branch. We called the device V-flow T branch for left subclavian artery reconstruction is separate a lot of clinical study. And if we get approval of this device, we can use the 1 branch distal stent graft combined with the proximal distal, the first stent graft and the branch stent graft and collection, and to realize all of the 3 branch arteries are reconstruction endovascularly. So in conclusions, there are still many challenges in endovascular constructions of the aortic arch. Clinical evidence of the limited number of the endovascular aortic arch reconstruction device is still lacking, and the result are not satisfactory. The design concept of the modular double branch provided a lot of way to reconstruct aortic arch. Further multi-center clinical studies are expected to confirm the safety and the efficacy of the device in near future. We will start the multi-center studies in next 2 months. Thank you for your attention. I'm so sorry because of my computer problem.
Thank you. Thank you very much. Excellent presentation. Open for discussion. I would like to invite Professor Stefan Holon to initiate it, please.
Thank you, Enrico. And Professor Go, great presentation and happy to have you live with us. I think that what is really interesting about your device is the ability to always position it very proximally the ascending, just at the level of the cinetubular junction, in order to avoid iatrogenic type A dissection and to have a maximum proximal sealing zone, and to have the proximal sealing zone in a real straight portion of the aorta. It seems that your device is quite short, 4 or 5 centimeters for the proximal piece. Would you consider having a second version with a slightly longer one in order to get it as proximal as possible?
Yeah. Thank you, Stephen. The first sections of the main body is a length 5 centimeter in length, and another one 6 centimeter longer. Yeah, according to the length of the ascending aorta, I think it's a very important factors. So majority of patients, I think 5 and 6 centimeter length is good enough, I think.
I think your device is will be adaptable to many patients, and is probably an option for a couple of acute type A dissection. Did you consider that?
Yes. Just because we have more dissection patients, so I guess maybe we use the Cook double inner graft or other kind of device. Maybe have trouble to fix the dissection cases. So I want to design this modular device for dissection patients.
Very nice. Congratulations.
Thank you.
Thank you.
Any comments?
Yeah, can I comment? I think this is a very creative approach and very exciting. But Professor Wago, is there not the potential for a gutter leak where the 2 aortic components have to seat within each other? Because the 2 branch grafts have to come through that junction, correct?
Yes, but the gutter.
So far, there's been none, but is that a worry that you have?
Don't worry about it, because of the gutter closed suture. When we made the device, the gutter has been closed already. So
Okay.
No, don't worry about the endo leak from the collection.
Very creative work.
Thank you.
I have a question. It's Matt Eagleton. It appears from the illustrations that the ideal orientation of the device would be with the branches along the anterior aspect of the ascending aorta, but it looked like in some of your post-deployment pictures that it wasn't oriented that way. Does it have a ideal location to orient those branches, or doesn't it matter?
Sorry?
Does it matter where you orient the branches or not for this device? Can you just deploy it without having an orientation to it?
No, I don't worry about because of the branch cover stance design, are different structure at the proximal, middle, and the distal in enough radial force at the proximal. So the patencies of the branch arteries is the most important for me when we design the branch arteries. I be concerned about this factor.
Professor Chen, any question, please? Any comment?
No, I have any question.
Enrico, may I ask a question? It's Hernan Bazan from New Orleans. Congratulations, Professor Wago. That's really innovative. Can you just describe the challenge getting the device into the aortic valve? So you don't have any kind of tip capture mechanism. So can you just describe how it's designed? Is it literally just a delivery by releasing the stent graft by pulling the catheter back, or how do you orient it? How do you accomplish this without a tip capture on the distal tip? Thank you.
Okay, this question is very, very important. The first design about the first main body delivery system is the curve, and the coil is very short. So don't care about the proximal. It's very short, so it's easier to deliver the in-body stent graft. The question is the third one, the descending, the third curved delivery system maybe make the first piece migration. When we push the last stent graft, descending stent graft, the delivery system maybe make the first stent graft migration. So we make the curved delivery system adjustable, you know, so to avoid the first stent graft migration.
Okay.
Thank you.
It was an excellent presentation. All of them are actually excellent presentations. I would like Dr. Veith to make some closing remarks, and then we are like 10 minutes beyond the time allotted.
Well, basically, this session has exceeded anybody's expectation. We've heard 5 really incredible, innovative talks, and my congratulations to all the speakers, the judges, and mostly to Enrico, who put this whole event together and made it as successful as it could possibly be. Thanks, Enrico.
Oh, thank you. Thank you all. It was a great afternoon, and let's generate some more exciting work. So next year, we have our 2nd annual competition.
Thank you.
Thank you to the judges. Have a great night.
Thank you very much.
Thank you. I'm very sorry. Very sorry.
That's okay, Go. Next time we see you.
Okay, see you next time.
Thank you, everybody.
Excellent.
See you next time.